Today we're going to be talking about an appendectomy, like you haven't seen before. The pathology we are discussing is appendiceal mucinous neoplasms. Sit back and let's get started.
Okay, so I'm going to go to our specimen for today. I'll introduce it onto the screen, and from there we'll see our first poll question pop up. What do you think the specimen is?
So again, our polls are anonymous, so don't be shy. Just feel free to click away, even if you don't know the answer, because we do discuss each and every single answer here. Can we or no, not yet?
Sure, why not?
Sometimes to keep the idea of suspense, we might refuse that request.
So a bit of a spread in terms of what this could be, and I think that was the goal of being a little bit intentional so that we wouldn't make it so easy for our first question of the day. The majority of respondents did select the right answer in the sense that we are dealing with an appendix. If we look a little bit through our specimen here, we do see, just come back here. So I think maybe we saw some keen eyes before I showed the mucosa, perhaps honed in on the configuration of the fat here, consistent with small bowel mesentery. Maybe people thought that we were talking about small bowel, and we do have a piece of small bowel here. And we can see that there's this tubular structure here that takes up the majority of the specimen. I could see why this could be in keeping with maybe a fallopian tube or even a penis. And then as an ovary, we've got enough structures here that might not land us on being an ovary, especially as we start looking at the mucosa. Okay, so what we've got here is a nice segment of terminal ileum. Okay, that's that small bowel component that we were looking at earlier. As we transition into the large bowel, we have our ileocecal valve. We have the appendix and a nice example of the base of the cecum. Okay, we've talked in previous sessions about assessing the serosal surface and being able to appreciate the tinea coli, and you can make that out on our specimen here. So it's a bit of a shine to it, but I think we can just make it out. Okay, you can see this band coming across here. So this is the tinea coli of our large intestine, and this is just the base of the cecum here. Knowing that, let's ask our next question and think about what are we going to call this particular surgical resection? What would you call this particular specimen?
I think this is a tough question.
It is a tough question.
Yeah. So if you thought the first question was easy, now it gets real, folks.
I think when we take a look at all of these different answers, we could apply most of these options to what we're seeing. Let's go through each of these one by one and think about what each of those are. Starting off with an appendectomy, a number of you have probably seen appendectomy specimens come across your gross bench. At some point, somebody in the chat just tell the group what an appendectomy is. Yeah, excellent. So it's just an appendix, or the resection of just the appendix with perhaps sometimes the attached mesoappendix. And so for scale, I'm going to show you what that might look like. Okay.
So keep in mind this image. And then we are fortunate enough, just like I imagine a lot of Surg Path labs would have a good old-fashioned classic traditional appendectomy specimen. Yeah.
I think it's pretty dramatic from what we're seeing between the two, but this is a really nice example of an appendix. And for fear of being shamed, I'm just going to move this out of the frame. I put it on a separate towel, so hopefully I'm not getting too much judgment. It's just
technically on a different stage.
Here, I'll put a probe and we'll put our invisible force field between the two.
Yeah, for the trainees here, you bring up a very good point. Ideally, you should only have one specimen on your bench, or at least one patient specimen on your bench, just to avoid any confusion, because these do not have names or labels on them. Once you start processing these specimens, especially if it's a multi-part specimen, you can get lost very easily. So the rule of thumb is often just keep it simple, keep it clean and organized, and ideally just one specimen per stage.
So an appendectomy is exactly what we just showed you, right? It's a resection of the appendix, typically with a little bit of the mesoappendix attached to it as well. So I added this extended appendectomy more of as a fun choice, but I think we could conceive that this would be an appendectomy specimen plus a little bit more. A lot of people chose this answer. Cecectomy, so sometimes it can be referred to as just simply a cecectomy, or some surgeons will call it a partial cecectomy. That's a resection of the base of the cecum with the appendix, but generally speaking, the ileocecal valve is spared. And so because we've got our ileocecal valve here, we don't count this as a cecectomy or partial cecectomy. This might also be called an ileocecal resection. And resections for an ileocecectomy would include a piece of the ileum. The differentiating part here is it includes the ileocecal valve with the appendix and some cecum plus or minus some ascending colon. With a right hemicolectomy, typically you'll see the same structures, but you won't receive such a significant portion of the ileum. Generally, it's a very small rim, and that's a big differentiating feature between the ileocecal resection and the right hemicolectomy. If we think through some of these answers, option B, C, D, and E apply to it, thinking about what we've got here as a specimen, I think the best answer would be, okay. So this is where we are. We've got an ileocecal resection. We've got some pretty interesting pathology with our appendix. Let's go into the chat now and get some descriptors for what we're seeing. I'm just bringing this up to the screen a little bit closer. Go ahead in the chat. How would you describe this? So we've got a dilated appendix. Absolutely. What else? What are some other descriptors? Yes, it does have a phallic appearance, and it is slug-like instead of worm-like. Yeah, and so you saw with the appendectomy specimen, it looks like a smaller, thin worm, and this is a little bit more bulbous and definitely much more dilated. So it's intact. Okay, is it firm or squishy? So hopefully this answers your question.
Does it bounce? No.
Good. Okay,
Good,
so
yeah.
we've got some
Fibrous
adhesions.
adhesions.
I
Good,
like that.
good observation.
Oops, point some of those out. So see these wispy strands of tissue on the serosa?
Yeah,
These
those
are
are
all
really good fibrous adhesions.
exactly nice examples of adhesions.
If anyone, what does the fibrous adhesions infer? What does that mean? Good.
Excellent.
Good. So inflammation, right? When you have something this dilated and big in such a confined corner in the right lower quadrant, it's very easy to incite an inflammatory reaction in that area. This is what that inflammation results in, where you get all these fibrous adhesions.
Yeah, so there's some really keen eyes. Whatever's happening in the appendix is pushing back into the cecum. Is this cone part soft? It's very much squishy. It's soft, definitely not firm or even rubbery for that matter. Very soft. Yes, we've covered the entire specimen silver nitrate. So let's get a sense of what people think is happening in terms of a differential for what we're seeing here. What do you think's happening here? And let's keep the differentials nice and broad. We've got a vote for mucosal. Excellent.
Good. Or
got the lamin. And for just the benefit of those that may not know what a lamin is, could we spell that out? And even for Hammond, whatever Hammond is. So a lamin is a low-grade appendiceal mucinous neoplasm. And then Hammond, just swap out the H for high grade. It could be an adenocarcinoma, absolutely. Ooh, net. Could be.
Please spell it out.
Oh.
Giant gum bezoar.
A net is a neuroendocrine tumor. Excellent.
I like that, bezoar. I don't know when's the last time I've seen a bezoar.
I don't know if I've ever seen one.
Okay.
Yeah, but definitely part of the differential, absolutely.
That's the one I was looking for.
I've got to put that into my arsenal of Scrabble and bananagram words.
Yeah, I think those are some good differentials, right? So as
Yeah.
I've always said, whenever someone asks you a differential, always have 5 ready to go and 5 more in the back pocket in case you get pressed, and always have a good spread or have some kind of approach, either non-neoplastic versus neoplastic, and then from the neoplastic, benign versus non-benign, or if it's in the non-neoplastic, is it inflammatory? Is it infectious related, or is it immune related? Those are usually good starting off points for organizing your answers to whenever someone asks you for a differential. And I think we covered quite a few of that, right?
I think that's the spectrum of potential differentials. When it comes to grossing, our eyes are very much drawn to this appendiceal pathology, but we always want to be aware that there could be secondary pathologies or secondary findings in our specimen. I don't know if you can appreciate, but if you can see something else going on the mucosal side, and that's a little bit intentional about not showing it, but anybody kind of pinpoint what's happening with the mucosa here? Any thoughts on what's happening here? Yeah, okay, so we've got some type of a submucosal mass. It's got this kind of golden yellow color, which is not coming crazy well to the camera, but there is a submucosal mass. What are some differentials for submucosal lesions, perhaps in the cecum?
So we have one already,
Yeah, so we've got the lipoma.
lipoma. Just as fair, right? Because that's often submucosal,
That's right.
or at least the classic submucosal. Good.
Submucosal lesions in the GI. What else could those be?
Something near and dear to me that was mentioned before.
Schwann.
Yes.
So schwannomal lymphoma. Excellent. So going back to the neuroendocrine tumor. Absolutely.
Yeah.
Yeah, low on the list. Met for sure. Lymphoma, some fibrous tissue, great. Okay, excellent. Yeah, so I think with the keen eyes here, probably favoring a lymphoma.
I'm converting people.
A lipoma, subtle differences in just spelling here. So we can take a quick cut across it just to see what
Ooh,
that looks
live
like,
cut, folks.
and then we'll get
Probably the
back.
first of a
Well,
few, right?
can't give away all of our secrets this morning.
I'm still trying to figure out if there's some kind of graphic or drum roll sign that we can add on our Zoom sessions here. Oh, nice.
Beautiful. Okay. How would we describe this then? Thank you for the drums. Homogeneous, great. Fatty and homogeneous, lemon yellow, I like it. Okay, so common things being common and entities looking the way they're supposed to, this is probably some type of submucosal lipoma. Caseous, not quite. We'd expect more white and some chalkiness in coloration. This is very homogeneous and texture-wise, it's very soft. If something was caseating, we'd expect it to be a little bit more friable and using food eponyms cheesy. Okay. So going back to our main pathology, what do people favor based on what we're seeing in terms of what we provided as a differential? And what do we want to see when we cut this? If we're going to cut this, should we cut this?
I think so.
I feel like we have to cut this.
Use your reaction buttons. Thumbs up for cutting it.
Okay, so let's do.
All right. Here we go,
Let's
folks.
find a good spot here.
Very nice.
Okay, let's get some gross descriptors of what we're seeing here. We've just got the one cut, but I think we can.
Had breakfast too.
Maybe folks are having breakfast, in which case we're honored. We've got semi-solid, we've got gelatinous, we've got white and yellow. It does look a little bit clear, doesn't it? This part on the right-hand side, a little bit translucent. Good. Okay, what are some other descriptors of what we're seeing on cut surface?
Any pertinent negatives, folks? The wall is thin. That's good.
It's very much in there.
Can we take a peek at the lumen? Is it easy enough? Don't want to disrupt it too much.
Yeah, so I think here is probably the closest I'm going to get to actually showing the lumen. The wall is very thin. We've got some of this gelatinous mucinous material kind of adherent to, and I think as I'm getting it into about here, I think that's the extent of the lumen that I can tell based on this slice. Okay, good. So there's no hemorrhage. You're right, because that would be much more red and brown. Coloration-wise, it's pretty homogeneous, and the lumen is definitely filled with a lot of this mucoid material. So we've only shown just the one cut cross section, but what are some of the elements that you want to be sensitive to in terms of scrutinizing the gross as you handle this across your bench? What are the features we're looking for? What do you want to look out for? Good. Okay. Excrescences, and where would we find those excrescences? Defects are important, and it's important not to transfer a lot of this.
Thank you, Brian. That was really giving me a heart attack. It's touching the serosa.
Good. Okay. So yeah, maybe some polyps. Any other features we want to look for and be sensitive to as we gross the specimen? So perhaps some diverticula.
Isn't an appendix technically a diverticula?
It is a true diverticulum.
Oh, fecalith is a good one.
Yes. Excellent. Okay, good. So yeah, we want to be able to look for a lot of those features, right? We want to take a look at making sure that there are any excrescences or more solid elements to the lesion itself. We definitely want to evaluate if there's any defects of the serosa, which I'm assuming we're talking about. And again, why are defects important? Good, exactly. So possible intraperitoneal spread, an extension into abdominal cavity. And I think going back to the one point about inking, that's why we want to ink these specimens ahead of time so that we can evaluate the outer surfaces.
Okay, we're just going to launch this poll because people were getting to some of the possible etiologies, but which of the following is not a typical cause for an appendiceal mucosal?
It's a spread.
Okay, so we've got quite a spread here. Nothing is 100%, of course, but I think so. We can all agree on that probably a mucinous neoplasm. So when you think about overproduction, it's either going to be an overproduction of mucin or some kind of obstruction that leads to the mucin from being excreted normally, right? Because mucin is always produced by any of the colonic epithelial lining cells. It's just a matter of whether it's too much or not fast enough to get rid of it. So mucinous neoplasm, by virtue of them just over creating mucin and over secreting it, would probably be one of the more common reasons. Diseases like cystic fibrosis, where the mucus is just so thick that it's not going to be able to flow so well. So that's an often common reason as well. So by that same extension, a hyperplastic polyp or multiple hyperplastic polyps can give you an overproduction of mucin. And similarly, if you've got some kind of obstruction, but that doesn't necessarily have to be regarding endometriosis, it could be a fecalith. That can also leave a lot of mucus or mucoid material behind and give you this mucosal appearance. The answer we were looking for is it's not typically seen in cases of IBD. Never say never, because if you have IBD within the orifice and that causes some kind of obstruction, that's possible. Typically, it's not one of the cardinal signs and symptoms of IBD. Either you're looking at Crohn's or ulcerative colitis.
Okay. Getting back to our specimen then, we've got this nice ileocecal resection. We've got a very dilated appendix. We talked about the contents and some of the findings that we'd be a little bit intentional about scrutinizing the specimen for. And so now when it comes to grossing the specimen, the first thing you want to do upon receipt is paint the surfaces like we've done. So we've painted everything with silver nitrate on the external surfaces. And then we're going to open everything up and allow things to fix. When it comes to the actually grossing, we're going to measure the individual components of our specimen. So the ileum, the ileocecal valve, will give a length and diameter of our appendix, and then also of our cecum. The first thing to do in the gross is evaluate the serosal surfaces and the adhesions noted along the appendix, making note that it was intact, that there weren't any defects. And then from here, take cross sections of the appendix, look further down the appendix to see what else is going on, and evaluate things like the wall thickness, what are the contents, are there other more solid areas, are there excrescences, are there other reasons and causes of what we're seeing to cause this obstruction. And then from there, talk about margins. How many margins do you think are on the specimen or are important perhaps? Yeah, okay, so we've got a nice little spread, and I think if we go through our specimen, and recalling that a margin is where a surgeon has had to cut in order to resect the specimen, starting, okay, so we'll start proximally. We've got a segment of our terminal ileum, and the surgeons had to cut across the ileum to resect that, so we've got one here. As we move across and into the colon, into the cecum, surgeons also had to cut to resect that. So we've got another nice staple line here. That'll be 2. And then you'd have to cut across the small bowel mesentery, so that would be 3. Here it gets a little bit perhaps not as clear, but I think the mesoappendix on this case is intact here. Okay, so that's all of this fat here, and that would have come out without any specific resection. So I think we can consider that there's 3 margins on this specimen. And I think the most important ones here are that proximal and distal one, because the small bowel one was just a bit away, perhaps less contributory to the pathology we're seeing. From here, we would take sections of our specimen. We'll take our margins as sections of some additional findings with the submucosal lipomas. When it comes to the appendix, what would be your approach? If this came across your bench today, would you be putting this appendix through in toto? Yes or no, or you're not really sure? Maybe you're going to phone someone, or maybe there's a different approach from where you're at. So let us know what you would do in this case.
I think there's a clear preference here.
Good. So I think it looks like the majority of people would actually put this through in toto. So what would your reasoning be for that? Why would you opt to put this through in toto? And in case anybody doesn't know, in toto means to submit the specimen in its entirety for histologic exam.
Just the appendix.
So what would your reasoning be to do? Okay, good. So there may be some evidence of microinvasion, and why would that be important then?
That's okay. We can go over that later. There we go.
This could be something low grade. We'd have to examine the whole appendix to make sure there aren't any high grade elements, and then to stage it appropriately. Absolutely. Going back to your microinvasion, yeah, because it'll relate to perhaps staging and treatment, could be related to seeding elsewhere. There could always be a small adenocarcinoma hanging out inside. I think our approach here would be to put this through in its entirety right off the get-go. And that may not be the case at all sites. So we're seeing spread in terms of what people would do. And not being sure, I think that's a totally okay place to be. And it's important to be able to have resources to reach out to and consult with, whether that be another PA, somebody more senior, it could be a senior resident, or even a pathologist, recognizing that the pathologies that we encounter are always unusual, and it's appropriate to then seek guidance and help from somebody that can provide it to you. Okay.
What do you do with all the mucin?
Yeah, so the mucin that stays in will actually leave, but I think you can see some of this mucin at the center kind of splitting away. So that way I don't typically submit that. It's really just anything that's attached to the rim of the wall of the appendix that goes through. And they'll end up being little strips because this won't fit necessarily in a transverse slice into a cassette. And so we'll end up having to either bisect and then just take strips from each half into a cassette.
Would you fit in a cassette?
Probably no more than 2, I think, given the diameter of our appendix. And depending on where we are, if it's a little bit more round, maybe only 1 would fit.
What do you do with the tip? Please explain.
Yeah, so I think with the tip, we'd still approach it the same way you would on a regular appendix, where you would try to bivalve it, but I would dissect the tip from here and then change my cuts to go perpendicular. And you won't get a nice intact bivalve tip like you would in a regular appendectomy sectioning, but the approach would be the same. Then from there, just representative sections of the cecum, again, of those submucosal lipomas. Take a look through to see if there's any lymph nodes in some of the fat here. And that's really about it. Use photography to your advantage. I think this particular specimen lends itself really well to having photography support and complement the gross description. But I think the old saying goes, pictures is worth 1,000 words. And I think this is one that would really benefit from a picture.
So I'm just going to do one more poll because we were talking about microinvasion and staging. I'll give you one staging question. If you don't know the answer, that's fine. But I think we'll review it regardless. So if you had acellular mucin confined to the muscularis propria, what's the most likely PT stage? We'll discuss it when we get to the staging question. I just wanted to put it in people's radar that the diagnosis really rests on what you see histologically. And to make a confident assessment, you need to put through everything entirely and looking at those stage criteria. We'll end the poll and then we'll come back to it later. We'll compare all the answers. And then hold on, share the results for now. So this is the spread. So most people are thinking PT2. All right, we'll get back to that. Let me get through our summary. Here's our specimen, nicely photographed by here, just showing all this ileocecectomy, I don't know how to pronounce it, with the significant segment of terminal ileum there. You can see the IC valve here, as well as mucin protruding through. And then, of course, a dilated, elongated, and enlarged appendix. Here is the serosal aspect. What's important here are a couple of things. The fibrous adhesions, which points to this being a chronically inflamed process, as well as the importance of inking, because we'll discuss what that means later on, giving you this kind of brownish hue with a silver application to this serosal surface. A close-up view of that mucosal projection, which again, in all likelihood, is probably mucin.
I think that's the reason, yeah, at the orifice.
At the appendiceal orifice, just a close-up view showing all these adhesions on the serosal aspect. With respect to appendiceal mucinous neoplasms, they can have a few interesting clinical presentations, right? Sometimes they can be presenting just like an appendicitis, so right lower quadrant pain, McBurney's point and all that. And you can also have appendiceal perforation. Given the inflammatory changes we saw here, I wouldn't be surprised if this presented like an appendicitis. There's also possible peritoneal dissemination, because if these things perforate, you can imagine all that mucin is going to go somewhere and it's just going to be confined in the peritoneal space. So you can have symptoms of abdominal distension. You can even have presentations of an umbilical hernia, and it might even have a palpable mass, an abdominal or pelvic examination. So the term mucosal, just remember, is a very general descriptive term that basically just refers to the dilation of the appendiceal lumen as the result of mucin accumulation. It's not a specific diagnosis per se, it's just a descriptive term. You can have mucosal of the appendix, you can have lip mucosals, and basically there any dilatation due to mucin. And its incidence is quite rare. It's about 0.2 to 0.7% of all excised appendices. However, the risk of developing an adenocarcinoma of the colon is 6 times greater in patients with a mucosal than in the general population. So that's the concerning feature and why these things are taken out to make sure. For the most part, these are low grade. High grade, as someone mentioned in the chat, is very rare. Nonetheless, that has to be examined. It can range from being benign, such as a mucinous cystadenoma, to the more malignant adenocarcinoma. It is determined mainly by histologic examination, plus or minus evidence of extraappendiceal dissemination. Clinical history will be important here. This is the grading. Let's put up that poll and see where you chose. Most people chose PT2, right? So this one was asking acellular mucin that's confined into the muscularis propria. Based on this, the correct answer, at least for this question, is a PTIS lamin. If you have epithelium that's malignant and invading into the muscularis propria, I can understand that's why you chose PT2. But in a lot of cases, it's acellular mucin. And that's why it's a bit painstaking to examine these things histologically, because not only are you looking at a lot of samples, but for the most part, you're looking at very empty, and you're really hunting for those 1 or 2 atypical looking epithelial cells, which can be difficult. It can be aided by immunohistochemistry if you need to. But yeah, it makes for a challenging thing, because not only are you looking for any malignant epithelium, but you're also looking at where they are, right? Because depending on where they're going to be, if they're found into the serosa, then you're into the T4 stages. And that's why it's important to ink the outside as well. And that's why I was a bit panicking there when a bit of that mucin stuck to the serosa of the small bowel. Yeah, so I was a bit panicked there. But then, yes, thankfully I remember, oh, yeah, it was inked. And then finally, some grossing pearls. So history, if there's any previous abdo surgery, and I'm keeping that vague, but basically in case there's been any type of potential reason for any inflammation in the area, what's another important history that might go along with an appendiceal mucosal? If someone in the chat can put that down. Another way of asking that question is, where do we typically see an appendix being taken out? In what other context? That's not GI related. Yeah, so some kind of an adnexal mass. If there was a history of an ovarian mucinous neoplasm or lesion, part of an ovarian staging, as some people have pointed out here, yes. Think of it, now we're approaching it from the other end. It'd be interesting to see if there was some kind of ovarian gynae history to this one, if there was any history of HIPEC. Is it just called hyperthermic intraperitoneal chemotherapy?
Yeah.
Yeah, so things like history would be important for this case in terms of history. You don't know whether this is a primary lesion or associated with another lesion. Could it just be a good old fecalith, for example, and there was actually no history? Imaging is important. There are some key imaging findings. One that keeps popping up is the calcified circumlinear sign, which is very specific for a mucosal. If there was any previous biopsy in this site, that'll be important. When it comes to orienting your specimen, really to know the lay of the land here, using your anatomic landmarks where you are. Assess for signs of perforation, because that would be important clinically as well. So careful for calcification. These can get calcified. So careful when you're cutting that. So that's where the imaging will be helpful. They would be able to see that. Be mindful of your margins, of course. Sample generously. And I just threw out this 2% rule that we usually ascribe to ovarian mucinous neoplasms. But I think, again, in a case like this, most people would probably be more comfortable submitting everything in total, recognizing how messy and extensive that would be. But I think just because we're looking for those malignant epithelial cells and where they are, that would be very important. And of course, do not forget the other organs.